نبدأ.
Okay. So again, good afternoon, everyone. I'm gonna welcome our dear colleague, Dr. Ibrahim Alabdulaal. I really thank you for your participation in this very much needed event for us. And we're gonna discuss today about the advices for the pediatric intensivist on how to manage the acutely ill adult patients if it comes to this stage in the pandemic. Hopefully not, but just to be prepared. So Dr. Ibrahim Alabdulaal, he's our colleague. He's an adult intensivist. He's a trauma also intensivist. He's our head of the surgical ICU in our King Saud University Medical City. So we are honored to have him today with us. And I'm gonna share the slides. And Dr. Ibrahim, تفضل.
الله يعطيك الصحة والعافية. أولاً thank you for having me and giving me this opportunity. طبعاً لا شك هذا honor أن يكون من ضمن الزملاء والإخوان وتعرفنا على إخوان وأخوات جدد وللأسف أنها تصير مع البانديميكس هذه ليتها غير السيتويشنز هذه. طبعاً والله الحمد الحالات المسجلة عندنا يعني في البلد ما هي عالية وأتمنى أنها تنحسر يعني، وباين ما شاء الله تبارك الرحمن وعي يعني الشعب، وباين أنه يعني فيه مهما كان استماع للنصائح من وزارة الصحة، وهذا شيء يعني لله الحمد بفضل الله سبحانه، يعني بفضل الجهود يعني اللي موجهة من وزارة الصحة. طيب طبعا احنا الموضوع هذا عبارة عن يعني what would happen if an unfortunate big break that happens to this virus in our country ويصير الكل يعني يشارك في علاج الادلت patients. فهي طبعا ما في فرق جدا كبير بين الادلت والبيدياتريكس، لكن حلو ان الواحد يكسر يعني زي ما نقول حاجز ما اسميها الخوف، بس يعني اقصد to give more confidence يعني لانه بالاخير الستاندردز واحده ABC and then call for help، والاحسن طبعا always call for help يعني من البدايه. فنبدا بسم الله. بسم الله.
May I ask you, Ibrahim, if you can, maybe we'll just maybe talk in English only, because we may be having international guests joining us. So
sure.
Maybe we'll just keep it in English. So excellent. So far, Dr. Ibrahim just told us about the preparation that's ongoing among all the ICUs nationwide for any potential COVID-19 effects of the pandemic. Hopefully, we will not reach to the stage when the pediatric intensivist needs to treat such a patient. But however, we just want to be one step ahead of this outbreak, and hopefully it will not reach there. Okay, Dr. Ibrahim, all yours.
Okay. Yeah, I do apologize not speaking in English from the get-go, but thank you for bringing that to my attention. So basically, we're going to start with the basics, the real basics of, as we know, anybody who's approaching a sick patient, we're going to approach this patient with the airway management, the breathing, the circulation. So I think I decided to go this route in order for it to be more organized and more systemic. So always protect yourself. That's my first, of course, advice. It goes without saying, you're protecting yourself, so you're also protecting your family and your colleagues. So always wear your proper PPEs. Now let's talk about airway. Of course, with my limited knowledge in pediatrics, I'm not going to compare adult to pediatrics, but what I can tell you is from my background experience in trauma is that adult airways are not straight. So that's the first thing to keep in mind. And what I mean not straight, I mean that you're going to be using the curved laryngoscopes a lot. And in order to reach to that point, of course, you need to be positioning the patients. What I know is that pediatrics, you would be putting an inch pad behind their backs just to keep the airway straight. This is not the real case in adults. In adults, you need to do a shoulder roll, put it behind the patient's back, open the airway with jaw thrust, chin lift, and use adjuncts, airway adjuncts. And so the airway adjuncts, we have the regular, of course, oropharyngeal, we have the nasopharyngeal, but on how to choose them, it's a little bit different than pediatrics. Pediatrics, you have a chart that tells you according to the height and weight, probably of the, I think the Brislow tape, are you still using it, or is it still?
Especially in infants, yes, we use the straight plates. And older children, you have both options to go with the curved plate or the straight one.
Yeah. Okay. So
you mentioned about
no, I was talking about the airway adjuncts, and when you're selecting airway adjuncts, do you have a specific chart that tells you what to select according to the baby, or do you measure it on the pediatric?
How we measure it? So usually we are measuring from the either from the tip of the nose to the ear tragus, which is for the nasopharyngeal airway, or from the tip of the mouth, the angle of the mouth again to the angle of the jaw.
So that's basically the same when in adults. So you're going to be using the orange and the green colored oropharyngeal. A quick tip is just to measure it from the tip of the mouth, the earlobe, the nasal trumpet, whatever can fit through the nostril of the patient, of course. Always pre-oxygenate the patient and attempt intubation, hopefully with a laryngoscope, with a curved blade rather than a straight blade. Curved blades usually go from sizes 3 and 4 in adults rather than the smaller sizes in pediatrics.
So what I may suggest for our colleagues now, maybe we can consider trying to, again, like with the simulation, try to remember how to intubate the adult mannequin. So maybe it's time for us to try that one again if we are preparing. If we have patients with this COVID-19 pneumonia, I think it's preferable to, and he's needing intubation. So probably some precautions are really needed for protection of the healthcare workers and the environment.
Absolutely. So, of course, we did talk about the PPE in the beginning. The helmet respirators nowadays are the preferred route when you're going to intubate patients. The risk of transmission has been shown to be less with these when you're intubating patients who are in stress. Now, let's talk about the should we intubate or should we use non-invasive first? I mean, you should look at the risk of transmission based on the clinical data that we got from the Wuhan epidemic before it became a pandemic. So risk of transmission with starting non-invasive ventilation on patients with COVID-19 to the healthcare workers was around 7%, well, 6 to 7%, which is significant.
Yes.
But most of those patients ended up needing the intubation. And so what they suggest is really don't wait, don't use non-invasive, just go ahead and intubate these patients. Now, who should attempt the intubation? It has to be by the most practiced, skillful person there is. So maybe the senior registrar, maybe the consultant on hand, maybe the anesthesiologist. And I think it has to be the most senior, most expert, possibly the first attempt intubation person that there is. There's no room for basically practicing or training or teaching in this situation. Now, the always recommended thing is using rapid sequence induction. And how we do it is basically with succinylcholine. Unless the patient has been hospitalized for a while, then you choose a different type of muscle relaxant, which is the non-depolarizing muscle relaxant. So succinylcholine, and you give the patient also fentanyl. You do every possible drug that you choose to prevent the patient from coughing and gagging, and hence, because it's an aerosolized procedure, you're trying to prevent or lessening the amount of aerosolized material in the air, i.e. preventing the patient from coughing, as I said. So you're going to be using succinylcholine in an adult. Usually, we always base our doses based on per kilograms, but we're fortunate that to have our patients to be a 60 kg person to a 100 kg person. So we always memorize specific numbers instead of memorizing the dose per kg. So I'd give a patient 100 of succinylcholine, 50 of fentanyl, maybe a little bit of midazolam, and again, you can give midazolam of 1 to 2 milligrams, and this is just if you base it on per kilo, you're going to be calculating. In adults, we have the luxury of just giving a dose, imagining that the patient is 75 kgs and above.
So what's again? Can you just remind us of the doses, Dr. Ibrahim? Because this is so usually, let's say average weight adult. So the succinylcholine is.
So I'd give 100 milligrams of succinylcholine.
Okay.
And I would give fentanyl 50. Now, depending on the blood pressure, if it's a good blood pressure, if it's a normal blood pressure, or it's a blood pressure that responded to a little bit of fluids, then I would give the patient midazolam as well. I'd give around 2 milligrams. And this is not per kg. This is just for a 100 kg person. We're always imagining our patients 75 and above, because if I'm going to calculate it per kg, it's going to basically take time. So that's a given luxury to us looking after adult patients. It's just memorizing fixed doses, and that's it.
That makes life easier for us.
So that the other thing that I can give if the blood pressure doesn't allow is probably etomidate. Now again, I would give 30 milligrams of etomidate to a patient. Yes, it will be taking a little bit longer to work than midazolam, but again, it's another thing that can offer a quick and easy intubation. So let's go back again. So the most expert person, protect yourself. Rapid sequence induction and intubating the patient, the most expert person. Use oral or use airway adjuncts. Make sure you pre-oxygenate the patient and use a curved laryngoscopic blade size 3 or 4. Of course, we didn't talk about the selection of the ET tube. Usually when it's a female, we go for 7.5, 8. If it's a male, we go for 8, 8.5.
Yes.
So that's a given. That's a given luxury. That's a quick airway talk there, and I think that's the most probably important thing. Now, there's one piece of advice. Adults, they have different transthoracic pressures. I mean, because of also the sedation, most of the adults will drop their blood pressure after intubating them. So always keep an eye on the blood pressure, cycle the blood pressure every 1 minute or 2 minutes on the machine. And I think this is a given. It's just a reminder. I'm sure most of my colleagues here are more capable and confident than I when it comes to this. So that's my piece of advice about airway.
And just to conclude,
of course,
just to remind the people that if you are having suspected COVID, it has to be in a negative pressure room because of the risk of the aerosolization of the virus, as well as keeping also with your PPE, also not forgetting the goggles, because during the COVID simulation, we saw people forget about the protecting the eyes. So the N95, the PPE, and including the goggles and maybe the face shield.
So that's basic. I was going to say, of course, do an X-ray, chest X-ray afterwards. The proper position of an ET tube would be about 2.5 centimeters above the carina. I don't know if this is a little bit different in pediatrics, but that's always where we want that.
That's easier for us.
Now, most of that, I mean, if we get to that point where an orthopedic person or gynecologist is intubating a patient, it means that they are going to be starting the ventilator as well. So a quick talk about how to start the ventilator is basically it's always on standby. It should have been tested by the respiratory therapy team on the morning of their shift. They test it and prepare it even after every use of every patient. So it has to be tested basically, then it's placed on standby. So when you hook it, of course, when we intubate a COVID-19 patient or a suspected COVID-19 patient, make sure to use the viral filter. Okay, let your RT show you the viral filter. Okay, it always comes in a package. I'm sure they have a couple of them laying around unpackaged for the purpose of demonstration. So ask them to just show me the viral filter and use that viral filter even when you're bagging a patient. So that's one of the recommended recommendations nowadays for COVID-19. So now that we intubated the patient, we're going to start the ventilator. We're bagging the patient. You give the ambu back to whoever's helping you bag the patient. You go back to the ventilator and you basically just turn it on and you put it on volume control, because this is what we are comfortable using in our hospital. You always go back and see what your colleagues are comfortable using. My training, I trained in a hospital that was comfortable using pressure control, and I had to go with the flow. But here in our hospital, I noticed that most of our RT team, or our RT colleagues, and most of my senior registrars and registrars, they're comfortable using volume control. So again, I'm going to ventilate this patient. Let's use an open lung strategy. Tidal volume for an adult would be measured according to the ideal body weight, and it's a bit different between men and women. There's how to calculate it. It's available on the application called MedCalc, which I think most of us are familiar with. It's available on both iOS and Android. So have that MedCalc available on your device, and you basically put in the height of the patient, male or female, and then it gives you how much is the ideal body weight of that patient. So you take the ideal body weight and you start the patient on 4 to 6 ml of tidal volume, because we're using volume control, and then you choose a
this is application. Is this the application you're talking about? MedCalc.
MedCalc. I would buy the Pro version because it has no advertisement and it has more equations.
Okay.
And I think it has a drug formulary in it, but I'm not entirely sure. But I use it a lot in calculating water deficit and ideal body weight and stuff.
Yes.
So we choose 4 to 6 ml per kg ideal body weight. That's on the volume limb. Of course, respiratory rate would be something equivalent to the patient when he was intubated. So I would go for 18 to 22, but then I will titrate according to CO2 because I need to maintain a minute ventilation. And maintaining that minute ventilation also will help me maintain a plateau pressure depending on the driving pressure. So we chose the volume, 4 to 6 ml per kg. I would go on an adult person with a PEEP of at least 8 to 12 starting point, because that is something that I will increase later on. They're always recommending PEEPs of 15 and above. But again, that all depends on the plateau pressure and the driving pressures that will be generated because we're using volume control. So that's basically it. That's what you want. That's the volume, the frequency, and the PEEP. Of course, if IO2 100, that's a given. And then call your colleague to come and help. Basically, get a blood gas, and then we can take over from there. But the whole reason for this talk is that how do I initially look after an adult male in situations of crisis? So I guess that touches base on talking about the airway and talking about how to start the ventilator in an adult patient. We could always talk about managing ARDS, proning versus ECMO. But I think when it comes to that point, I think already the patient is handed over or triaged to an adult ICU. I don't know if you agree. Maybe you can leave that talk for a different day. Yeah.
True. So probably, so after initial stabilization, at least you can also then titrate your therapy with the advice from a colleague, either direct advice if he can join you in the rounds, or maybe sometimes it could be just a phone call or a video conference with him.
Absolutely,
just to give the specific suggestions, because we cannot cover everything, every aspect. I noticed in the adult you are using the proning a lot in the ARDS recruitment. Is that what I noticed, the videos?
So yeah, so proning patients in the ARDS have been showing a lot of fantastic results, and the whole idea is because when patients are on their back, there's the weight of the heart. There's a lot of, let's call the ARDS lung a wet lung. So all of this is all going into the dependent parts of the lung, and these are the mostly used ventilated alveoli. Now, when you prone a patient, you take away the weight of the heart, you take all that fluid down, and you open up other alveoli by your recruitment methods, and at the same time the circulation stays the same. So basically you're ventilating now parts of the lung which are the dependent parts, plus the new alveoli that you recruited, and you're taking all that water down with gravity. So usually proning
so for you in adults, it's proven that it is effective. It improved the outcome.
Absolutely,
because in pediatrics, it's not that clear. We keep it as maybe a last measure, but as if I noticed you in adults, you use it almost like it's like a routine. You do the proning issue.
And the early the better. Actually, it started to be once I face issues with oxygenation. Of course, with ARDS, you're going to be facing issues with oxygenation. But let's say that I used APRV just to the point where I make sure that I get the patient hemodynamically stable. Get my lines in. After I got my lines in, I make sure that all my lines are secured, and now I have my patient who is stable. Then I will prone. So the earlier the better in adult. And it's been studies actually looked at proning patients about full day, but then the latest recommendations and guidelines were 16 hours, and 16 hours were enough to jump with the numbers. I don't specifically remember how much is the improvement rate, but the recommendation, and no doubt, is early proning. Patients did better with ARDS management. This is in the adult field. I don't know if adolescents are the same. So let's say pediatric of 12.
Yeah. So occasionally, as you mentioned, if we are stuck with a very high FI2 requirements, and sometimes it's like a last resort before we go ahead and put him on high frequency. For you in adults, you don't use high frequency much in ARDS.
after proning and ECMO, we basically stopped using it. So, I mean, last time I used a high flow frequency was maybe around 2013. And this is during my first fellowship in King Faisal Specialist. So that was a while ago. So yeah,
that was a while. Sure. Okay. So would you like to mention something else about the ARDS, or would you like to move the septic shock component?
So of course, keep the patient euvolemic. That's a given, because as again, lungs are and we can always look at the Berlin definition as well of ARDS just to remind ourselves. And that's all my advice here about airway and starting the ventilator, and why do we prone in adult ICU when it comes to ARDS.
Excellent. Okay. Septic shock.
Yeah. So which takes us to circulation really. We have a lot of luxury here because we have standard vital signs. We don't have a schedule that tells me based on age group what is the vital signs. Okay, so what is basically let me take it a step further. What is shock in adult? It's basically whatever gives me signs of hypoperfusion. Okay, so lactate going up, base deficit is in the minus, and it's horrible. I have change in sensorium, decreased urine out, but all of this tells me that my patient is shocked, and I think it goes the same with pediatrics as same physiology really. But what is our approach here? Is basically replace what's lost in terms of hypovolemia, if it's a hemorrhagic shock, or if it's a septic shock. Now, what do I mean by replace what's ongoing loss? So give fluids, expand the circulation, just give boluses of a liter. Okay, so crystalloid can work. Give blood if it's blood. We don't need to calculate based on weight, so I would give a liter to an adult male or female, I mean, instead of just calculating it per weight. Now let's talk about sepsis and what's so different here than pediatrics. I honestly don't have a clear answer to that, because it's at the end it's a septic shock, and it can affect humans and non-humans, adults and pediatrics.
True. So let's take what's particular about. So, for example, recently in our pediatric septic shock, we are becoming more careful with the fluids, not to give a lot of fluids. So maybe after the first bolus, we're trying to rush with the inotropes. And of course, these guidelines just keep on evolving. But you mentioned, like, from your side, you are giving the fluids initially 1 liter crystalloids.
So this is an attempt to expand the circulation, really, to improve cardiac output, because that's the end game, right? So I would give a liter of crystalloid to the patient, try to expand the circulation. And this is not just in septic shock. This is in any shock, really, even neurogenic shocks and adults, even in hemorrhagic shock. I would give that initial crystalloid liter. Now, when it comes to bleeding, it's a bit different story. We immediately try to control the source of bleeding and give blood, massive transfusion protocol, then consider inotropes. And cardiogenic, septic, neurogenic, I would start after my first liter, really considering inotropes. Now, I do, of course, need to have source control, i.e. if it's a ruptured viscous, take the patient to the OR. If it is a abscess formation, I need to drain it. If it's bacteria, I need to remove the central line. If it's UTI, of course, I need to search for the reason why the patient has UTI. So source control, antibiotics.
Source control. And for which, do you have any preference which inotrope to start with, or from the septic shock? Let's say if it's septic shock, because this is what we are expecting with the COVID, to face more and more.
Absolutely. Absolutely. So it's no doubt I was getting to that. So antibiotics give you initial fluids, and then start considering inotropic support. Now, what is the best inotrope that we know of is basically epinephrine. The problem with epinephrine is all that arrhythmogenicity, doesn't work on all receptors, and so what became the gold standard is norepinephrine. Okay, and so basically we mix it the same. I'm not sure how if it's mixed the same in pediatrics or is it diluted more, but how we mix it in adult ICU is we take 8 milligrams and we mix it into 50 ml of saline, and the patients would get about 0.1 microgram per kg. And it's easier in adult ICU. We go by milligrams per hour, so 1, 2, 3 milligrams, and then as it goes up, we always consider early on adding another vasoactive medication like vasopressin. So the two inotropes that we usually use and abuse, this is how I call it, is norepinephrine and vasopressin. Now, you would find some of our adult patients on dopamine only because it's the only drug approved to be given peripherally in this hospital, or I think in multiple of our hospitals in the kingdom, is dopamine approved to be given peripherally until you get that central line in. When you get the central line in, then norepinephrine is the usual drug of choice to go. It depends on how you practice inotropic use, but the moment I reach 10 of norepinephrine on an adult patient, I would add vasopressin, just to have that synergetic effect with norepinephrine. So these are the two drugs of choices in adult shock when it comes to inotropic use. Now, if I have this patient who has florid shock, let's say that I'm going on norepinephrine of 30, vasopressin is in the background, the patient did get some boluses of fluids, then probably, well, steroids are on board, then probably I would be reaching for epinephrine as a third drug to be added to the equation. Of course, always get an echo, search for the cause, treat the cause. So it's basically the same in the adult pediatric realm, but we tend to use a lot of norepinephrine and vasopressin. What I heard is, I'm not, so based, most of my information about pediatrics is what I heard. I don't read in pediatrics, of course. So what I heard is that dobutamine and dopamine is used a lot in the pediatrics. Yeah. I'm not really sure, but is that...
Yeah, it depends on the stage of the shock, whether it is a cold shock or warm shock, blood pressure, stability. We also frequently add something like milrinone or dobutamine just to have also some afterload reduction. Do you use also milrinone similarly or not that frequently?
So our use of milrinone is basically to augment that forward flow of the heart, especially in patients with the high pulmonary pressures, really bad cardiogenic shock. So we do use milrinone in that field. Nowadays, we started using it with the spontaneous subarachnoid hemorrhages with cerebral vasospasm. And there are a couple of articles there. But our use here in the Department of Critical Care at KQUH, at least it's very little. We tend not to use it a lot because
so that's unlike the pediatric age group. If you may allow me just one point about the steroids, because the steroids again is part of the septic shock algorithm. However, if you are dealing with the COVID-19 ARDS with a septic shock, I think we just need to, I'm not sure if there is any new guidelines about it, because steroids for ARDS COVID.
Yeah.
It's been controversial, and most people saying no, don't give it.
Yeah, that I'm not well aware. Again, COVID-19, it's an infection, right? So you're giving steroids to also further decrease the immunity of this person. Again, it's a little bit tricky, but if I have that patient who's not responding to high doses of inotropic support, and I know that this patient is adrenally insufficient. Remember that adrenal insufficiency in adults, it's a lot. Anybody who's above 65 is probably adrenally insufficient at one point. I mean, so again, I'd use it to improve the cardiac output overall, the cardiac index of the patient. But I'm not. I honestly, I didn't come across any evidence that supports not using it in COVID-19. This is at least because I didn't look for it. I didn't go.
So probably this has to be maybe raised.
Search for it. Yeah.
Yeah. So probably I will suggest, at least if colleagues having any COVID-19 patient with a septic shock and considering steroids, at least to maybe consider taking updates from the infectious disease team colleagues. They may have more details about it. That's my suggestion only. Excellent.
So that's airway breathing. Breathing, there's nothing much, and then circulation. There's just one point about breathing that that came across my mind actually this morning, because we're using high peak low tidal volume, and we were dealing with high plateau pressures in adults. You would see some patients with pneumothorax. Okay, so there's a little bit of a difference between needle decompression in pediatrics and needle decompression in adults. So when you have that tension syndrome going on, tension pneumothorax developing, the recommended site for the needle decompression would be fifth intercostal space, just anterior to the mid-axillary line, and use a 16 to an 18 gauge needle. Make sure it's a short needle though, and then always insert the chest tube. So that's one point that is a little bit different here in adult and pediatrics, and we're going to be seeing a lot of pneumothorax when it comes to the ventilating ARDS patients. God, I hope that we don't reach to that point. So that's airway breathing, circulation. I think a couple of things that were raised in the message that you sent. Yeah. So sedation and analgesia, we can just take it quickly. We always use the RAS score when you're sedating a patient. We have Glasgow Coma Scale, of course. I don't know. You guys have APGAR score, I think, or something like that.
We have
the Glasgow
sometimes comfort score, or there are several scoring for the depth of sedation. So your type.
So Glasgow Coma when the patient is not sedated. When the patient is sedated, then we use RAS score. And basically what you want your patient to be is between 0 and -1. If you are paralyzing the patient for proning and trying to improve oxygenation in a severe ARDS patient with the open lung strategy, and everything is failing, you're going to be paralyzing the patient. And so when you paralyze the patient, you really need to sedate the patient. So what we achieve is a -3 to a -4 sedated patient. Now, what are our drugs of choice? Of course, some elderly patients will be sedated enough with fentanyl. Fentanyl doesn't sedate. It's a good analgesic drug, but to the point where it actually sedates elderly people. So fentanyl sometimes is enough. We tend to use a lot of propofol if the blood pressure can handle that. And why do we use propofol? Is basically we can stop it quickly, assess the patient quickly, and then put them back on propofol if we need to give them propofol again. We do tend to use midazolam if the blood pressure is not under control, because it has a less side effect on blood pressure than propofol. And nowadays there are units where they actually sedate patients with ketamine, but we have to be careful here, especially if we're trying to recruit lungs and whatnot. So I think basically we can develop the habits of understanding the adult dose of the propofol and the adult dose of fentanyl. I usually give my patients around 50 to 250 of fentanyl per hour, and I give them propofol of 1 to 4 per hour, depending on the blood pressure, and this is of course per kg. But if we're talking about midazolam, it's 1 to 2 milligrams per hour as well. So it's easier when it's an adult patient, no doubt. And there's no much difference between sedating an adolescent or an adult. It's the same standard measures. So I don't think I can add anything there to the team.
Perfect.
So that's analgesia sedation. Again, renal electrolytes, when we reach the point of does the patient need dialysis, then I think already the patient is triaged and handed over to the adult ICU. But yes, electrolytes, of course, we'll be seeing a lot of hypokalemia nowadays because of all that Ventolin that we're using, trying to recruit lungs. The dose in adult, if it's a peripheral line, you can give up to 10 milliequivalents per hour of potassium. If it's a central line, you can give around 20 milliequivalents per hour. Of course, in a monitored bed, that would be better. Now, you'll face a lot of refeeding syndromes because usually they are dehydrated, not eating. The moment you start them on fluids, start resuscitating them, their magnesium, potassium, phosphate all drop, and this is a common phenomenon, I think, in both age groups, adult or pediatrics. So that's something to keep in mind. There's nothing really special or different here than just making sure that the electrolytes are under control and corrected.
Yep. And for adults, generally, yeah, the acceptable urine output is not per kilogram. It's just an amount per hour, same like before, or it's
so it's actually a good question. Now we do tend to base it according to weight. Okay, so an accepted adult urine output would be about 0.5 ml per kg per hour. But again, 100 kg person, you would accept a 30 ml per hour. So that's a quick way of just remembering it. So
perfect. Thank you. Okay. Any other issues you would like to mention about? What about the main IV fluid as a maintenance? Let's say the patient is not dehydrated, or just as a maintenance rate. Which type of fluid? What's
so any crystalloid would be fantastic. Just always look at the sodium of the patient, the chloride. We tend to use, unfortunately, a lot of sodium chloride in our practice, and we always cause metabolic acidosis because of hyperchloremia. It's always iatrogenic here, especially in adult renal failure patients. So I tend to use D5 half normal saline if I keep my patients MPO, for instance. If I can avoid use of IV fluids, depending on the patient's volume status, I would just feed my adult patients. Try not to give them a lot of crystalloids. Ringer's lactate is a good crystalloid because it's more isotonic to to our adults. It's just it has potassium and calcium, so you have to be careful with the long-standing bedridden patients with calcium. You don't want to give them more calcium or potassium for what it's worth. So really, there's no big difference. Now, calculating maintenance, we actually base calculating maintenance on the pediatric equation, which is the 150-20, or we use the 4-to-1 rule. I would maintain a 100 kg person on 120 ml per hour. But again, it all depends on urine output, hydration status, and I always make sure to look at my patient on morning rounds and at night rounds, just to consider stopping the crystalloids. As I really, in adults, you don't want to give them a lot of chloride, if you know what I mean.
True. Excellent.
That's how we calculate it, really.
Dosage and preparation. Maybe I will skip this slide about we are talking about the dosage medication. You mentioned already about the app that you recommended, that about the MedCalc.
Yeah.
And
so MedCalc has ideal body weight calculator, and has also how to calculate sodium deficit, bicarb deficit. It has a good acid-base analyzer as well. So it's a useful tool for any intensivist, really, or any person who deals with critical care patients. But it does, I think stick to your hospital formulary when it comes to mixing medications, because this is what the hospital wants you to do. It depends on your hospital and your clinical pharmacy. But it's always nice to have that formulary also available on your device. Like what we have is Lexicom, and we do have that on our devices in the hospital. So I think that's my piece of advice.
Excellent. Okay, maybe about the feeding and gastric prophylaxis.
Sure. So always, we all know this is a common shared physiology. Feeding is the better option. Use the GI rather than TPN, of course. Again, nasogastric tube or feeding tube, which is the yellow one. Once I intubate a patient, I immediately ask for orogastric airway, because one, I will deflate the stomach after all that bagging, and then two, I would start feeding immediately. So it's always advisable to start feeding immediately. An adult can take feeding up to 50-60 ml per hour. So that's a good volume, really. I don't know, compared to pediatrics, how is it calculated? But feeding early on is always recommended. Now, gastric prophylaxis, in terms of stress ulcer prophylaxis, we tend to use a lot of proton pump inhibitors, especially when the patient is intubated, because this is part of the ventilator-associated pneumonia bundle prevention, or bundle of prevention, or prevention bundle. But nowadays there are a couple of studies that actually it's increasing the chances of C. diff and whatnot. And so our hospital had recently dropped it from the guidelines, or the bundle, the VAP prevention bundle. But some of my colleagues are still using it. I tend to use it, especially if I have a patient who's on steroids or are on aspirin. So we always use proton pump inhibitors, and check with your hospital what is available IV and is cheap. Stay away from the Nexium because it's expensive. But the bottom line is check what is your VAP prevention bundle, and stick with the guidelines.
True, very true. Thank you very much. Maybe a couple of minutes for the peripheral IV access, CVC.
Sure. So we all know that resuscitating patients is better done with the peripheral lines. No doubt they are shorter, they're wider, and so you could resuscitate patients quicker. However, why do we need central lines in such patients of, let's say, ARDS and septic shock? Because one, you're offering a line where you can use inotropes securely, and two, you're giving your colleague nurse more lumens to utilize. So say antibiotic in one lumen, the other has the inotropes running, the other has fluids running, and it's easier for the repeated blood investigations. We always prefer the peripheral line for resuscitating patients, and this is a common physiology, I guess. Then we insert central lines. Now, our choice usually would be an IJ. It's no doubt cleaner. Ultrasound machines nowadays made it much safer. I was prep and drape for an IJ and a subclavian. If I failed doing an IJ, I would go and do a subclavian. Femoral lines are the quickest, but they are the dirtiest. So whenever you want to insert a central line as an emergency, use the femoral area. Once inserted, try to change it the next day, depending on how exhausted your service is. So it's a common practice. Now we tend to use the 12 French. It's a slightly larger central line than what you guys have in the pediatric realm. Triple lumen is always the best, as I mentioned. And we always use ultrasound. There's always, it's a Sildiger's technique, aseptic technique. I don't think there's anything different than adult and pediatrics when it comes to inserting the central line using the ultrasound. I think the only difference probably would be the subclavian, because we have a higher subclavian in the adult world, and we do have the clavicle as a beefy bone to really poke before you go down and go to the subclavian, rather than in pediatrics. I think the anatomy is a little bit different, but in adults, I think always go with IJ. But if it's an emergency situation, just femoral line would always help.
Mentioning the emergency, what about the intraosseous? Let's say the patient is shocky, and for the intraosseous sites.
Yeah, so that would be my second line, actually, before inserting a central line, when it's the when the patient is crashing in the emergency department. So, of course, this is what we do in trauma, but because we developed our skills and we have the ultrasound and getting a single lumen, large caliber central line in the femoral area, it became quicker for us. So it probably would take one of my senior registrars less than if not 5 seconds, it will take them less than probably 5 minutes to get me a secured single lumen large caliber line. Although I don't recommend doing so, I would go peripheral, then interosseous, as we mentioned, and then a central line. But because we're quicker, it's easier. Nowadays, we're using the femoral route access with ultrasound machine, quicker and more efficient. Excellent. And it's available. You have the resources here, so it's not like in a field somewhere.
Yeah, true. Although the resources sometimes may be overwhelmed, so that's why keeping the basics and I'm just thinking about the worst case scenarios. The intraosseous sites are similar like the pediatric, or do you go also other sites as an intraosseous?
Of course, the best site would be the humeral, and this is based on literature from the oncology services. But in order to insert a humeral interosseous, you need somebody who's awake and cooperative. They're going to hold their hand, you're going to touch, you're going to look for basically where you're going to insert. So humeral would be the best action. But in situations where patients are crashing and they're not cooperative, of course, you have long bones and always the tibial plateau is the site of choice. Making sure, of course, that there's no fracture in that limb. Then that would be a choice on inserting an intraosseous
Perfect.
line.
Excellent. Okay, you want to mention anything about the DVT prophylaxis, pressure ulcers? I know they are more common in adults rather than pediatrics.
Yeah.
So.
Yeah. So for pressure sores, unless the patient comes with a pressure sore from home, and we document it. Of course, there's the pressure sore prevention bundles that is implemented in the services. Our nurses are doing a fantastic job in terms of turning the patients daily. But no doubt, especially those that are prone, you're going to be looking after protecting their eyes also from pressure sores. You're going to be protecting their jaw, the chin, their shoulders, and so you'll probably need to use more pillows than usual. But again, it's a service that is implemented in the healthcare environment here, and I think our nurses are doing fantastic when it comes to pressure sores and pressure ulcer prevention. But DVT prophylaxis, usually the recommended dose for an adult who's below 100 of heparin is 5,000 international units subcutaneously BID. If they're above 100 kg, then it would be Q8 hours. Okay, so that's something to start from the beginning. Heparin is always nice because you can always stop heparin and give protamine sulfate if something happens, or if you need an urgent intervention for a patient. Enoxaparin would be a good choice also for those who have a normal kidney function and in the realm of the orthopedic patients, spine patients, trauma patients. That would be always a good idea. But if we're talking about septic shock, COVID-19 patients, always heparin would be my go-to. I would start heparin on patients, unless I know that the patient has history of heparin-induced thrombocytopenia, which is documented on their forehead. Then I would not use it. But I would use heparin subcutaneously for anybody who's less than 100 kg. So 5,000 units international BID. If they're above 100 kg, then the recommended dose would be Q8 hours. So that's about DVT prophylaxis.
Excellent. Thank you very much. Let me just double check with our colleagues if they have any questions they have raised. I'm just learning this technology new, so anything that comes in mind. Meanwhile, what about the hemoglobin levels? Maybe I forgot that. Usually, do you have a strict hemoglobin transfusion in adults, or?
No, actually. So there is this. The trial came out, but unfortunately, that trial didn't look at burn victims or cardiac victims, or cardiopathy patients. Where a hemoglobin of 7 is actually safe. But of course, when you have a patient who's hypoxic, who's sick, who's in shock, I think a hemoglobin of 9 and above would be agreed upon. Now, any patient with myocardial demand, like showing us troponinitis or rise in the troponin or troponin leak, as the cardiologist would call it, I would always make sure that their hemoglobin is above 9. So, so sick patient, hemoglobin 9 and above, that would be the target. Somebody who's healthy, young, is in the ICU for just monitoring because he has COVID and he's not really hypoxic. Then I think I would accept a hemoglobin of 8 and above. I certainly would not leave him at 7. I would give him a unit or 2. But 9 is our cut point. I'd make sure that I give blood to those patients if they're sick.
Excellent. I think I'm not seeing any questions from the colleagues. So here I just wanted to share with them. Maybe this is if they want to. I'm not sure if they can click on the link or they can just scan the QR This is one of the sites. It's an international ICU support forum. I think there are more than 1,000 colleagues now sharing the concepts about the COVID. It includes both adults and peds ICU, and there are always about maybe 50 people online at the same time, at least. So I would really recommend this website for colleagues, because they may have, especially if they don't have access to adult colleagues who can support them. Again, an early adult colleague consultation would be perfect. That will be the best situation. Any other resources that comes into your mind, Dr. Ibrahim, please?
I would. There are a lot of resources really, but I would really stick to. There's the MCRIT podcast, MCRIT website. So EM crit from critical care. So it's a short, okay, .org. But it's basically based on an intensivist talking and then sharing his resources. So don't take, how can I put it? So he has recommendations. Don't take them for granted unless you go and check his resources and his references. But it is a fantastic job that he's doing, both on the blog and the podcast. And,
so what's the name? What's the name of it? I will share it on the screen again. Sorry, it is M.
So EM. From emergency medicine. EM. CRIT, which is a short for critical care.
CRIT. MCRIT.
Yeah. Yeah. MCRIT.org.
.org.
Org.
Okay, perfect.
Yeah,
so I just
put it
there on the screen.
So he has a very good blog website, and he has very good videos on some techniques on how to approach COVID-19 patient and how to intubate this patient, especially adult patients, and just check his references before you take his talk for granted. I always listen to this guy. It's Dr. Scott Weingard, and he's a very good intensivist, really.
Excellent.
And there's also a blog called Life in the Fast Lane. It does share a lot of adult ICU resources. But again, you need to take those reference and then go search for the papers and the articles.
Excellent. Again, Dr. Ibrahim, I'm really appreciating all your time and efforts. We exhausted your efforts today. Thank you very much.
We didn't do anything.
You did a perfect job. I learned a lot today. It was a refreshing time for me. I'm really appreciating all the colleagues. We had up to 63 colleagues online at the same time. We'll be recording this one. So hopefully other colleagues who want to later to come back to it, I will try to post it on the YouTube maybe, and I will share it with the colleagues just to share the knowledge together. Hopefully we don't reach that stage, but it was an excellent refreshing. I'm really appreciating, and just thank you and stay safe, all of you.
Allah يعطيك العافية. شكرا. Thank you very much.
Thank you. شكرا Ibrahim. Thank you. Assalamu alaikum. Thank you. Bye-bye, everyone. Okay, thank you, dear colleagues. I will just close for now. Okay.